going to do a brief little presentation here, and this is a combination of different things that I've presented at different places with relation to this project. So just to give you a little bit of tour of myself, because Gail had asked that we do a bit of an introduction to ourselves. So I got my PhD in clinical psychology at Jackson State University in 2013. And then following that, I went to Yale for a T32 postdoctoral fellowship in substance use prevention research. I stayed there as a research in a research position for a few years, and then 3 years ago transitioned to the University of Rhode Island, and I'm there in the Department of Psychology and the clinical psychology program in a tenure track line. So that's kind of a brief little bit about myself. I thought it might also be useful just to share a little bit about my research program more broadly. So broadly, I'm focused on post-traumatic stress disorder. And so many of us are probably familiar with those core symptoms of PTSD. I'm particularly interested in engagement in self-destructive and reckless behavior, which is the new E2 criterion that's been added to the 2013 DSM-5. And in particular, I'm interested in the intersection of PTSD and substance use disorder. And so my research really seeks to answer two questions. The first is why PTSD is associated with substance use disorders. So what are those underlying mechanisms that lead individuals to engage in substance use following traumatic exposure? And then secondly, for whom is this relationship strongest? So can we identify people in the population who are exposed to trauma who are more likely to develop a substance use disorder? And I currently actually am just starting today year 5 of my K23 award. And that project aimed to look at proximal associations through the use of ecological momentary assessment between PTSD symptoms, emotion regulation, and substance use. And specifically, we looked at those relationships amongst women who are currently in active relationships where they experience domestic violence and use substances. So we're just finishing up actually data collection there and hoping to move to the data dissemination phase at this point. So as far as my COBRE, really the goals of applying for this award were to extend my expertise to cover opioids. And that was an interest of mine in particular because I was developing an R01 application that was focused on opioid use in relation to post-traumatic stress disorder. And I wanted to be able to enhance the competitiveness of that award by providing some feasibility and acceptability data. As far as the intersection between PTSD and opioid use disorder go, we see really high prevalence rates of both traumatic exposure and PTSD in particular amongst populations that are characterized by opioid use disorder. So somewhere between 40 and 60% of people who are identified by opioid use disorder are reporting some lifetime history of PTSD. And we know that compared to individuals with either PTSD or opioid use disorder alone, those with the co-occurring PTSD opioid use disorder have far more worse outcomes, more clinically significant outcomes. They have more severe PTSD symptoms and opioid use disorder patterns. They have greater impairment in functioning and rates of disability, as well as a wide range of other co-occurring conditions, including medical, mental, and behavioral health problems. So obviously this co-occurrence is quite important. As far as my research goes, I'm very interested in affective processes in relationship to the co-occurrence of PTSD and substance use. And so it wasn't shocking that I was primarily interested in opioid self-medication as an important factor as it related to trauma. When we look at the opioid use literature, there's far less that has looked at self-medication, although we do obviously know that that's likely a driving factor for opioid use following traumatic exposure. We see amongst individuals who use opioids that they're reporting their primary reason for use is to relieve emotional pain. And amongst the few daily studies that exist, we do see that earlier levels of negative affect are predicting later opioid use within the day. There's some evidence to suggest that this perhaps might be more prevalent amongst individuals with PTSD. So the existing research has looked at opioid use more broadly, not within trauma populations particularly. But we do know from other data with other substance use that individuals with PTSD are more likely to use substances in contexts that signal negative reinforcement. So in other words, we know that the motivation for substance use for individuals with PTSD is more likely to be one of negative reinforcement, reduction of distress than for other populations. My research has been increasingly interested in better identifying objective measures of affective functioning. And so that's essentially measures that we can use that don't rely on people's subjective report or telling us what they're feeling. And there's a couple of reasons for that. First, we know that people may not actually know what they're feeling. And so there's a lot of evidence to suggest that individuals with PTSD have some deficits in emotional clarity. They may not be able to identify or differentiate amongst their emotional experiences. We also know that sometimes they do know, but they don't know until it's too late. So they may not know that they're experiencing a negative affective state until it's quite intense. And at that point, it's very hard for them to act on that in an effective and skillful way. And the third thing is that people may not want us to know what their emotion states are. So there might be some stigma or norms related to sharing of emotional experiences. And so for all these reasons, it's really important for us to have other ways to detect emotion experience beyond just relying on people telling us what they're feeling. And so for the opioid grant that I've developed, I'm particularly interested in using speech as one of those type of objective measures. So we know from the existing research that affect produces reliable changes in different processes that are encoded in speech. So things like articulation and respiratory processes. We also know that there's at least a little bit of evidence to suggest that there actually are some identifiable speech features that are specific to both PTSD and opioid use disorder. In other words, if we have people engage in some kind of structured speech task, we record their speech, we can predict with pretty good likelihood whether or not an individual has PTSD or opioid use disorder based on these specific types of processes. But the existing literature has really been limited in the sense that the speech is almost always, or not almost always, has always been collected in a structured manner. What that means is people are going into the lab, they're doing some kind of recording. There are some questions about the ecological validity of those types of methods. And also it's only being collected at a single time point. And obviously emotion fluctuates. And so it's quite dynamic, a dynamic process, and it's something we need to take into consideration in our measurement of it. And so the idea here is that if we're able to better identify objective features such as speech, we might be able to better detect the onset of opioid outcomes that are relevant. So things like relapse or even perhaps overdose. And we might be able to therefore engage in early intervention and prevent some of these negative outcomes. So with that in mind, my CoBRA project really, as I said earlier, it was more about providing some feasibility, acceptability data for doing a larger R01 where we'd be looking at speech as an objective measure alongside ecological momentary assessment in the real world, and doing this with individuals identified by opioid misuse. And so to do so, we wanted to address these 4 specific aims. So first, we wanted to be able to show that we could recruit and retain individuals who are trauma exposed and have opioid use disorder in the community. And that's actually really important because almost all of the research that has relied on daily method approaches like ecological momentary assessment with opioid populations has used clinical samples. And oftentimes those have been samples of individuals who are receiving treatment and so aren't actively using substances. The second is that we wanted to be able to identify prevalence rates of PTSD in the community sample with opioid use disorder. Again, the existing data is coming from clinical samples, and clinical samples are more severe. We expect to see a greater range of symptoms in community samples. We wanted to show that EMA was acceptable for this population, and also that people would be willing to allow us to record their speech. So as far as the speech recording goes, what that is, it's called Priori. So it's an app that somebody downloads onto their phone. Folks out in Michigan developed it. And it starts recording as soon as somebody picks up a phone call or dials a phone number. And it only records the the participant's speech. So that's a really unique feature of it. So you train it to only record the participant's speech. It won't capture speech from the person on the other end of the line or from individuals in the environment. And so we wanted to be able to show that people would be willing to allow us to record their day-to-day speeches. And then lastly, we wanted to demonstrate length of time necessary to capture some opioid outcomes. So things like overdose, relapse, as well as to show adequate compliance and point of participant fatigue. So that was really the goal of the COBRA project. Just to give a little bit of background here, so it's 100 people that we're proposing collecting data from, again, trauma-exposed folks in the community who have opioid misuse. We're bringing them in for an initial session. During that session, we're going to conduct structured diagnostic interviews on them to get rates of PTSD, as well as assess acceptability of speech. We'll be then for 30 or 90 days following them using ecological momentary assessment. So 5 times a day, they'll provide ratings of different behaviors of interest. Those include affect ratings and opioid use outcome data. And then they'll come in at the end of that 30 or 90 days, and we'll be assessing at that point some acceptability around ecological momentary assessment, as well as any reasons for missing data. So things like incarceration or treatment. And I'm just going to end here with some barriers that we're kind of juggling right now. And that's essentially that because of COVID, we haven't been able to start data collection for the project. We were supposed to start essentially at the same time that we got shut down, like literally 3 days before recruitment was starting, the lab shut down. So we're kind of tackling this idea of how do we manage remote recruitment and data collection. We actually just last week got approval from our IRB to begin remote data collection. So we're anticipating starting that this week, but some of the concerns that I have that perhaps maybe I can open up to the group are that really the goals of this project were to provide some data on recruitment and retention, acceptability of EMA within a community sample using methods that we would typically be using, and switching to a remote format that might kind of disrupt some of those aims in particular, as we're then really showing about recruitment and retention using remote methods and acceptability and compliance using remote mechanisms. So those are some of my kind of current concerns. But that's kind of that. So I guess I'll open it up to the group if anybody has any thoughts or questions.
Nicole, this is Jody. That was really outstanding and fascinating and an exciting area of research. And I'm completely impressed at your multitasking abilities.
Thank you. I appreciate that.
So, you know, I'm wondering what's the prevalence of PTSD, and I guess the PTSD that leads to these negative outcomes. I guess that's a subset of PTSD. Is that fair to say?
You know, I mean, I think there's a lot, but I mean, I think the prevalence is about 50%. I think you're probably right that there's some aspects of PTSD that might increase, that might be linked more strongly to some of these outcomes. I think also there's some questions about at the daily level, how PTSD symptoms might proximally predict, like what kinds of PTSD symptoms might be proximally related. Sure.
Yeah. Well, I mean, first I was wondering, what's the prevalence in the general population? What's the prevalence in opioid use disorder, and what's the prevalence in incarcerated populations?
Yeah.
My sense is that it's very high, probably over 50%. Yes. In the latter two populations. And I'm just fascinated by this, that you can pick up on speech the predictors of PTSD. And I'm wondering if, it might be worth exploring other things, because speech is just one component of communication. There's all this, eye movement um, and physical and then there's this whole, you know, uh, well-developed field of facial recognition software. Um, and I'm wondering if there's a way to get some savants from that field to kind of see if they can add or supplement that. And then the other thought that just came to my mind is, boy, if you have the ability to describe PTSD um, and opioid use disorder with some accuracy, I'm wondering if you can get your hands on a data set of 911 calls,
Oh,
because those you probably could get some outcome data, as in like there was an overdose there or not. And I bet that population has a high prevalence of both PTSD and opioid use disorder.
that's
Just
a
a
really interesting point, Jody.
just a thought to
Yeah,
while you're struggling with your enrollment, just explore another
yeah. No,
aspect.
I think that's a great idea. That's something I'm definitely gonna look into. I hadn't even thought that far, but yeah, all of those are valid. It's really interesting with the speech. I mean, they haven't, to my knowledge, it hasn't been applied to like predicting proximal risk for substance use outcomes. So we know that it'll predict like whether somebody has the disorder. But we do know that there's some evidence now to suggest that it'll predict proximal risk of like suicidality. So we do know that it'll predict health behavior outcomes. It's just a question. I mean, we'd have to do some training around the data to see what are the specific features that seem to be particularly relevant to opioid use outcome in particular.
I'm just thinking through the of course there's a trajectory of opioid use disorder as people develop it and expand, and it gets worse and worse, and they're depending on what happens. And of course, hand in glove with that is the traumas that they go through along the way, or that they went through before to get them involved in it. And then there's the day-to-day, you're using, you're high, you're back to normal, you're in withdrawal, you're scrambling to get out of withdrawal. And I'm sure there's a sort of a both a day-to-day and a trajectory um, in the PTSD disease as well.
Mhm.
So it seems like there should be a lot of variability day to day, depending on what's, if everybody's nice to you someday and everything's going well, maybe your PTSD is not such a important thing. If you're stressed out about something, or you got triggers about other issues or other micro traumas, it's going to be a lot more present. It's going to affect your voice and all your behaviors, and then also I'm sure the disease evolves over time,
Yeah.
and people recover from it as well. So
Well, that's an important point, and that's really the reason why some of these laboratory paradigms that have been used to capture speech in the past probably don't have the best ecological validity, because the fact is, as you're describing, people's symptoms fluctuate, both within days, but also across time. And so if there's some way for us to be able to better capture what that day-to-day variability looks like, I think that it'll help us to better identify some of those speech features. And, the goal of this is to be able to then take that data and really apply it to intervention. So whether that be at the clinical level, so for instance, I can call in as somebody with an opioid use disorder to a clinic. They can perhaps, just based on my speech over the phone, be able to help identify what's my risk for negative outcomes. Or even within the individual level, I can myself maybe have some software on my phone where I'm, trying to, I'm receiving treatment for an opioid use disorder. I can speak into this program on my phone, and it'll tell me in any given moment what is my risk right now. And
yeah,
so perhaps there's some utility there in that.
Your voice is getting squeaky. You better take take another dose of Suboxone.
Yeah, no, seriously, something, I mean, who knows what the potential is, but it's something that surely hasn't been explored thus far, so I'm excited about it.
All right, nice and short meeting today. Nicole, thank you very much.
You're welcome.